Thank you, Bill, and thanks to Less Cancer for inviting me here like last year. And I'm really glad to actually be a moderator of a panel of some fabulous experts and speakers who I have the pleasure of asking to join me on stage so that we can probably get some introductions done and start delving into the focus around screening. Professor Peshkin, right here, from Georgetown University, and I'll do introductions in a minute. Dr. Yoshida from University of Virginia, and Dr. Uldrick from the Fred Hutch Cancer Research Center. I think we had our fourth speaker who has some change, and I think we just have 3 speakers for today's panel. Well, I'm really glad to moderate this session, and I think in our conversations while we were talking about how the focus of a panel on screening would be, I think it was really important to bring in a focus on one of the most widely utilized and a widely utilized intervention which touches virtually the lives of everybody who interacts with the healthcare system. And as much as we are talking about a lot of policy issues, I think this panel would probably bring in some of the individual risks issues as well as issues which will have broader implications on reduction of cancer incidence in the United States and across the world. And I was hoping to hear from the range of expertise that you have on the panel today around a whole range of topics ranging from genetic screening to GI screening to HIV screening and HIV and cancer screening. So without further ado, I think we could get started with a bit of introductions, and maybe we can start with Dr. Yoshida from the right there, and then maybe you can give a little bit of overview of what you do as well as what sort of motivates you in cancer prevention, cancer screening.
So my name is Cindy Yoshida, and I am a gastroenterologist from the University of Virginia. I am passionate about colorectal cancer screening. So as a gastroenterologist, I do a lot of colonoscopy, and speaking to you students predominantly, colon cancer screening is one of the things that we don't like to talk about a lot about, right? It's kind of messy. My name is Cindy Yoshida. I'm a gastroenterologist at the University of Virginia. My passion is colorectal cancer screening, and I'll just brief introduction for that.
Yeah. Well, okay. Maybe you want to say something about the type of clinical expertise that you provide and teaching that you do at the University of Virginia.
So the clinical expertise that we have is that I am really just a gastroenterologist. I do colonoscopies. But from my area of research that I'm interested in is decreasing healthcare disparities in colorectal cancer screening. So we're predominantly looking at areas in Southwest Virginia and in rural areas in Virginia where we have a decline in colorectal cancer screening. I'm sure many of you know Katie Couric started this 80% by 2018 campaign that we just ended to increase colorectal cancer screening. We see colon cancer screening has improved over the course of the last decade in a lot of different areas, but there is a significant disparity in rural areas. Getting people to actually get colon cancer screening, so people who are have less education, who have less access to health care or primary care providers. So our area of study is about increasing that ability to get colon cancer screening to that particular population.
Thank you. Tom, you want to talk from there or come
I can
here?
talk loudly from here as well.
I think they're working back again. Maybe the mics are working apparently.
Oh, great. Hi, so my name is Thomas Uldrick. I'm a medical oncologist and hematologist. I am currently working at the Fred Hutchinson Cancer Research Center and serve as the deputy head of global oncology there. I've really dedicated the last decade of my life to understanding cancer in people with HIV, and in this pursuit have been involved in understanding better ways to manage cancers that occur in this setting. A large number of these cancers are caused by other viruses and are preventable. There are 37 million people living with HIV globally now, and with effective antiretroviral therapy, cancer has become the leading cause of death in this patient population. The commonest cancers that occur in the setting of HIV include a viral-associated disease called kaposi sarcoma, for which there may be ways to prevent tumor formation by early detection or treatment of the viral infection. This is the leading cause of cancer death in much of Africa for children and adults, #1 cause of death. Other cancers include cervical cancer and anal cancer, which are caused by HPV. There has been a long effort to prevent cervical cancer by effective cervical cancer screening programs, and so trying to figure out the appropriate way to screen for cervical cancer is very important. For the 25 million people living in sub-Saharan Africa, cervical cancer is the leading cause of preventable death in adults. And lastly, lung cancer is becoming the leading cause of death in people with HIV as well. And this is another area where research may inform how to screen or have early detection methods for people with HIV that may be somewhat different than the general population. So I'll stop there, but certainly there's a lot of room for discussion of screening in patients with HIV.
Thank you, Professor Peshkin.
Hi, good morning. It's a privilege and a pleasure to be here. My name is Beth Peshkin. I'm a genetic counselor and professor of oncology at Georgetown University. And to the students, I'll say genetic counseling is one of the most rapidly growing professions in the healthcare field. So keep your eye on that. And it's certainly been a dream career for me. Most of our research at Georgetown has focused on hereditary breast and ovarian cancer from the early days in the mid-1990s when these genes were identified. And our research has evolved as the sophistication of testing and questions have become more complex, looking at what types of individuals are interested in genetic testing and who declines testing, and then how people do psychologically and medically after testing. And now we are focusing our research on developing adjuncts to genetic counseling to make it more accessible to individuals as the demand for genetic counseling and testing has grown. About 1 in 400 individuals will test positive for a BRCA1 or 2 mutation predisposing to hereditary breast and ovarian cancer. About 1 in 300 or more will test positive for a mutation in Lynch syndrome, which is a common form of, still rare though, for hereditary colon cancer or Lynch syndrome. And many of these cancers are preventable either with screening, particularly for colon cancer, or risk reduction for ovarian cancer and breast cancer. And there's now a debate that's been raging for many years about doing population screening for these types of hereditary cancers because family history is not as predictive as we once thought. And I think this is segueing us into a debate about whether we should all have our 20,000 genes sequenced to look for preventable, not just cancers, but heart disease and other disease risks. So hoping that we'll be able to touch on some of these important topics today.
Thank you. I think those are fabulous introductions and sort of good segues into our conversation. I think one of the hallmarks of screening is that we are talking about individuals who are asymptomatic, who are healthy or generally appearing healthy, and the goal of screening is to detect a disease early enough in in the natural history course so as to prevent death due to a particular condition. But screening, although it sounds as the most important thing to do, also has some downsides to it, which do not always get highlighted in conversations around importance of screening, including harms of screening and the risks of false positives or false negatives and the workup which comes up with that. And I just wonder, during your conversations, you could probably touch base on some of those aspects as well. But to get us started, maybe I could start with Professor Peshkin and just sort of get into this big topic that is obviously in the news all the time, but it's appearing in direct-to-consumer ads about, testing your genetics, your genetic sequence, whether it's 23andMe and a whole range of companies that offer those direct-to-consumer testing. I just wonder what your perspective on those tests would be, and how do you think they would be beneficial, particularly in the context of hereditary cancers, but also broadly, as you referred to, population-based screening, if there's not much of a link with family.
So thanks for the question about direct-to-consumer genomic testing. I think this is on a lot of people's minds. I don't know how much time we have because there's a lot to talk about. But I think, when you think about developing an infrastructure for population screening, it's very hard to imagine how we would deliver genetic counseling and results of genetic testing to hundreds of thousands of people. And the direct-to-consumer market has, and some of the laboratories, the commercial labs that are offering genetic testing for hereditary cancer, I think have begun to make a dent in this and really make us think about what kind of service delivery we want. You could right now get tested for dozens and dozens of cancer susceptibility genes for $250 or less through commercial genetic testing labs. And of course, you can go to testing companies like 23andMe for less money than that and get a handful of cancer susceptibility genes assessed. So in March of 2018, the FDA approved the 23andMe to market testing for 3 BRCA1 and 2 mutations out of thousands within these genes. And these are 3 mutations that occur with increased frequency in people of Jewish descent. About 1 in 40 people who are Jewish will test positive for one of these 3 mutations that you can get done through 23andMe. The potential benefit, and if you go on the website, you'll see this, people testing positive who had no inclination from their family history that they were at risk for hereditary breast and ovarian cancer. As long as these people understand what the implications are and they get that test clinically confirmed and they get counseling, I don't think that in and of itself that is a bad thing. What we are more concerned about is the many, many people who are concerned about hereditary cancer who go to websites like this and test negative and don't understand the limitations of the negative test result. That number one, if you're not Jewish, that test really doesn't mean anything, and that there are many other genetic and non-genetic risk factors for hereditary breast and ovarian cancer. So the message is that if you are concerned about hereditary risk based on your personal or family history, or you're worried about it, a consultation with a healthcare provider or a genetic counselor is important. 23andMe just received approval to test for another colon cancer susceptibility gene, which you probably never heard of, called MUT-YH, which is relatively rare, and the interpretation of that is a little bit more complicated. So I think this is the beginning of a slippery slope of more testing that we're going to see. But the other type of information you can get through direct-to-consumer testing is you can get your raw data, meaning you can get information about all of your genes that is not interpreted in the same way as those quote-unquote health reports that you get back. So they are much more prone to error. We think about at least 40% of information that you get from your raw data is wrong. And so you may have seen articles in the New York Times, people, in fact, a medical student, I think, or a young physician who thought he had Lynch syndrome based on looking at his own genetic data, and it was wrong. Somebody who thought he had early onset Alzheimer's disease, and it was wrong. So not all direct-to-consumer genomic information is created equal. Some of it is not accurate. So again, there's a lot more to say about this, but I think the bottom line is that genetic counseling and interpretation of these results is very critical before people make life-changing decisions about getting colonoscopy at 25 or getting breasts or ovaries removed based on a direct-to-consumer test.
That's extremely valuable advice and your perspective on this. And I wonder, you mentioned the colon cancer test. I wonder, Dr. Yoshida, you might want to comment on, broadly the available range of tests, which obviously are quite a few, including now, as you alluded to, the genetic testing version of it. But how about the balance between getting at-home screening tests versus going to the doctor and, getting a colonoscopy, getting a sigmoidoscopy? What would you sort of see in terms of impact on the population would be the way to go? Or I understand, obviously, it's all being used, but what is your perspective on seeing eventual reductions in colorectal cancer incidence?
So I think one of the most important messages for colorectal cancer screening is that one test is not, a lot of data has shown that one test is not the only way to get colon cancer screening done. If you went ahead and you asked everybody to have colonoscopy, a significant number of the population would not have colon cancer screening because there's that big ick factor to having a colonoscopy, taking the prep, doing the procedure, et cetera. So in order to get colon cancer screening done effectively, we need to have options. And that's one of the biggest reasons that the United States Preventative Services Task Force came out with a number of good options for colorectal cancer screening. So in 2016, the current recommendations are you can have a colonoscopy every 10 years, so take a scope, take a look. You can have a FIT test or a guaiac-based stools test. So you actually go home and you take a stool card. This is not in your doctor's office. Your doctor doesn't do a rectal exam and get a stool test. You have to take it home and you actually collect stool and take a little sample onto the card and collect stool to see if there's blood in the stool, microscopic amounts of blood in the stool. Then the one that's the most marketed now, you've probably even heard this on NPR, is the Cologuard test, which is a stool DNA test. It started out to be initially a stool DNA test, but then after a course of time, they added the blood test to it. So it tests not only for blood in your stool, but it also tests for DNA in your stool. I'm going to step back here and tell you a little bit about why that's important, and why that test works. When we talk about colon cancer and the formation of colon cancer, the vast majority, about 90% of colon cancers start as polyps. So polyps are little growths that grow in the colon, and they grow larger and larger over time. There's a number of genetic tests, a number of genetic changes that happen as the polyp grows from a small polyp to a dysplastic polyp to a cancer. As that polyp grows, it releases and sheds blood in microscopic amounts, and it also sheds DNA as well. And so that DNA can be found in the stool, and the blood can be found in the stool. So testing the stool for blood and testing a Cologuard with the DNA is also important. Technology has also increased our ability to look at the colon. So there is another test called a CT colonography, which is a CAT scan. And in that test, you can actually, you take a prep and you clean out the colon, and they are actually able to do a CAT scan to look for polyps in the colon that way as well. And a CT colonography is every 5 years. So the other tests, the fifth and final test is a flexible sigmoidoscopy. And flexible sigmoidoscopy is the scope test, but you're only looking at about a third of your colon. And the reason that was popular, when we first started doing colon cancer screening early on in the 70s and 80s, 1970s and 1980s, the vast majority of polyps were found in the left side of the colon. And so a number of the studies have shown that if you can do colon cancer screening in the left side of the colon, you can prevent a lot of colon cancer. Today we know a little bit more that colon cancer occurs throughout the colon, and polyps can occur throughout the colon. We found more recently that a lot of the colon polyps that we have newly discovered are these flat colon polyps. They're called sessile serrated polyps that lead to cancer. And these sessile serrated polyps, polyps lead to colon cancer predominantly in the right side of the colon. So getting back to what tests are available, those are the available tests. So the colonoscopy, if it's normal, is every 10 years. The FIT test, which is the stool for blood, has to be done every year. The Cologuard test, was kind of iffy. The United States Preventative Services Task Force said it could be done every 1 to 3 years, but it's an expensive test because it tests for the DNA, and so it costs about $700. So because of that, they cut it back to doing it every 3 years. The flexible sigmoidoscopy can be done every 5 years, and the CT colonography, the CAT scan, can be done every 5 years. So people always ask, what is the best test to get done? And, Sid Winnower, who was one of our gastroenterology colleagues and was the head of the National Polyp Study, really made it a point of saying that the best test for colon cancer screening is the one that gets done. If you don't do the test, then you're not going to be able to prevent colon cancer at all. So I think that's the biggest message for colon cancer screening.
No, thank you. I think that comment was extremely helpful, and I think, as you said, getting the test done is a key issue, and you alluded to some of the disparities that exist in terms of access to a lot of those tests, and I hope we can come back. I hope we can come back in the panel to addressing some of those questions. But let me move to Dr. Uldrick for a second, and I wonder if, you work a lot in AIDS-associated cancers, and obviously one of the hallmarks of screening is to focus on populations that already have a high baseline risk so that you can have a much better impact or the effectiveness of screening protocols. You alluded to Africa, but in the United States, do you see, I think I'm going to an issue which is really hot off the press, which I think President Trump mentioned yesterday, which is eliminating HIV in the next 10 years, which I think is also as a goal. And I think it's also something which the United Nations Joint Agency for HIV/AIDS has promulgated as one of the goals for the next 10 years. I wonder if you can speak to some of the evolving issues around management of HIV-associated cancers and screening of those cancers in the U.S., and you see that changing over the next several years. I know anal cancer is one of them, but maybe you want to talk about others as well.
Sure, this is a very broad question, a very important question, and I guess we should start with the idea that treating HIV will not only potentially end the HIV epidemic, but also prevent cancer. So the goals of HIV rollout are really to have 90% of people who are infected with HIV tested, have 90% of those enrolled in therapy, and 90% of those successfully treated with suppressed HIV viral loads on therapy. And mathematical models show that with a 90-90-90 approach, HIV will not only be better controlled in people who are HIV infected, but it will prevent spread of HIV and ultimately lead to the end of the epidemic. And so there are broad efforts internationally to reach these milestones. We are at various levels of that goal in terms of people on antiretroviral therapy. In sub-Saharan Africa, it's country by country is different, but in Uganda, where I work, for example, we're at 60%. That's actually not too far off from many of the outcomes in the United States. And certainly getting to 90-90-90 throughout the entire United States will have a very important impact on preventing cancer. HIV therapy as prevention, I know the question is a little bit around screening, but around prevention, has been shown in randomized studies and large epidemiologic studies to decrease the two commonest cancers, KS and lymphoma, by over 50%. This is a proven form of cancer prevention, and so I think we need to keep that in mind. When you think of the cancers for which we do screening, the focus really is on cervical cancer and anal cancer. The CDC defined cervical cancer as an AIDS-defining malignancy in the 80s, and that was because of studies done in women with HIV, finding that they were very high risk of having precancerous lesions, things we now call cervical intraepithelial neoplasia. These are the lesions that people look at when you go to your gynecologist for cervical cancer screening. And not only are the lesions more prevalent or more common, but they also come back more frequently. And a lot of the original observations occurred at a time when there was not effective therapy for HIV. And so the screening model will change over time, as more and more women fall into the 90-90-90 and are started on therapy early in their HIV infection rather than later in their HIV infection. The immune system in the cervix is not normal. There's a need to better understand the immune system so that perhaps we can better figure out how to modulate it and prevent the progression of cervical cancer to premalignant lesions to cervical cancer. But it's critically important to continue cervical cancer screening efforts. We know in countries where they exist for HIV-infected women, the rates are substantially lower than many countries who cannot afford to have cervical cancer screening. I think you've brought up the point of over-treatment and over-diagnosis. One of the issues with cervical cancer screening is how to manage lesions that you see, how frequently should you be monitoring, and how do you address them when you see them. The common treatment is either to cut off the lesion surgically or to burn it off with something called cryotherapy or other similar approaches. And so these do have, you do need to select women carefully and not over-select women for screening. There's great enthusiasm to include things like HPV, which we know causes cervical cancer, but women with HIV commonly shed the oncogenic virus without necessarily having lesions. So figuring out how to streamline therapy without leading to overdiagnosis is an important problem that many are trying to solve. Additionally, I think globally, when we think about cervical cancer screening, we have to recognize that a screening program, US-based, requires a strong pathology department, a force of nurses, a force of physicians, and this type of infrastructure does not exist in many parts of the world. And so really we need to look for innovations in how we effectively screen for women and come up with affordable innovations in this space.
Thank you. I think those are very important points. I think one point which you alluded to, and I think it's universally applicable, is to select the ideal age to initiate screening and obviously also to exit screening. I know it's relevant in the GI cancer context in relation to the recent revision from, I guess, 50 to 45. I wonder, Dr. Yoshida, you might want to talk a little bit about that age initiation issue in terms of, and then maybe Dr. Ulrich, you want to talk a little about the HIV one as well.
So I'm sure many of you know that in 2016, the U.S. Preventative Services Task Force said that colorectal cancer screening should begin at age 50. And the vast majority of colon cancer is in people over the age of 50. So the big problem is, well, let me just back up. So what we've seen is that colorectal cancer screening has worked, and that over the course of the last 15 to 20 years, we've seen a 30% decrease in the incidence and the death rate from colorectal cancer, largely due to colorectal cancer screening. And that decrease has been predominantly in the people who are screened, right? The 50 to 70 or 75-year-old population. What we have seen, though, so there's been a marked decline in the last decade, particularly. There's been a decline about 3% per year in that 50 to 75-year age group. But unfortunately, we've seen an increase in colorectal cancer, particularly rectal cancer, in young people between the ages of 20 and 54. And if you look at that, so in an older age population, the death rate and the colon cancer incidence is decreasing. But since the 1990s, the colon cancer and rectal cancer rates in young people has been rising. It's been slow. It's been between 1% and 2% per year. If you look at that, that's a scary number. I mean, they estimate that by 2030, there might be 128% higher incidence of rectal cancer. And it's not really known why that is. There's a lot of studies looking at that. Is it because we use more antibiotics unjudiciously, because we might use more antibiotics in our meat and our produce? Is there a change in the gut microbiome? Is there an increase in obesity or a decrease in levels of activity? I don't think we really understand that. But we do know that we have seen a marked increase in that population. So as a result, by looking at a number of different models, last year in May, the American Cancer Society recommended that we decrease colorectal cancer screening age to the age of 45. And I'm sure that led to a lot, it did lead to a lot of controversy. Many of you probably saw a lot of articles, like in the New York Times, about whether or not we could really afford to do that. What's important to remember about decreasing the colorectal cancer screening is that if you look at that percentage increase, it might be a 1 to 2% increase in that age group over time, but the absolute numbers of colorectal cancer is very low. So even though we might be talking, and it's in the 100 times lower, so even though we might be talking about high levels of colon cancer in the 50 to 70 age group, 75 age group, even though they're increasing rates in that younger age group, the total absolute numbers are low. What that means is if we start screening all the 20-year-olds for colorectal cancer, we would be screening a lot of people for a little bit less benefit. What they found for less benefits, a lot of people would be screened and very few people would have colon cancer or colon polyps. So I think what's coming out of this now is that age cannot be the only indicator for colorectal cancer screening. There has to be more than just age that puts us at increased risk for colon cancer, and we know so much now. We know that family history particularly has come about in the last couple of months. There's been a number of studies that shown that the people who are at younger age who have colorectal cancer are almost always people who have a family history of colon cancer. And so understanding genetics and understanding whether or not that risk is present, looking at people who are obese, looking at people who have metabolic syndrome, who have decreased activity, those are going to be the people that you are going to be screening. And I think the message that's particularly important among young people, since you guys are in that group, is that if you have symptoms, almost all the people in that younger age group who presented with colorectal cancer had symptoms. They either presented with the change in their bowel habits, or more commonly, they presented with blood in their stools. In the olden days, we used to say that a 20-year-old who presented with blood in their stools for sure just had hemorrhoids, and he didn't have to worry about it. He just had a hemorrhoid or a fissure or something. He didn't have to worry about it. But in today's age, if you have blood in your stools, it's very imperative that we actually act upon that. So colon cancer screening might not happen in the 45-year-old age group universally because health insurance, we have legislation to deal with. The health insurances are not covering it in the vast majority of cases, so it would become out of pocket for the vast majority of people. I think what we're looking now for is how to screen the right people that are younger.
Well, thank you. Maybe, Dr. Ulrich, very briefly about HIV. I know the about cervical cancer screening first, but also if you can talk about the age of screening as one of the initiator for cervix. You said 30 and above, I guess that's one of the recommendations, but also for anal cancer. You might also, not in this age context, but broadly about some of the efforts going on in HPV-associated anal cancer screening.
Sure. So I will try to focus just on the HIV population. For cervical cancer, the recommendations for a woman who's not already being screened for cervical cancer is at time of diagnosis to be screened for cervical cancer, have a repeat evaluation at 6 months, and then yearly. There are questions as to whether this level of intensity in the beginning is necessary, and there are efforts to identify how to space out these measurements based on well-controlled HIV, measurements of a good immune system using a blood marker called CD4 count, and based on whether or not someone has a normal PAP test as well as no evidence of an oncogenic virus. This is HPV 16 or 18 mostly. For anal cancer, many of the issues are similar to cervical cancer. The viruses that cause the tumors are the same. The type of cells that are infected by these viruses are the same. But the management is different. There is an emerging effort to develop anal cancer screening methods. There is a large NCI-sponsored study called the ANCHOR study looking to see whether or not treatment of early lesions versus observation of early lesions prevents invasive cancer. And the results from that study will really inform whether or not treatment of premalignant lesions, these are things that are found on an anal pap exam, prevent cancer. There's a lot of morbidity when you treat an anal premalignant lesion. And so this is an important question. And the only other thing I want to briefly talk about is lung cancer screening.
Please.
There has been a recent guidelines for low-dose CAT scans for lung cancer screening, and the general population, age 55 to 75, who have a heavy smoking history, 30-pack years or more. It's unclear how, given that people with HIV have a substantially increased risk of lung cancer, they develop it actually approximately 5 years younger than the general population, and they also have more concurrent lung problems, perhaps due to previous lung infections. And so the appropriate age for lung cancer screening is currently a research question. I think most experts would say to follow the general guidelines, and that would be the same for colorectal cancer screening or breast cancer screening. These are diseases for which association with HIV is not that strong.
Sure. Let me quickly go to Professor Peshkin. You might want to comment. I think one of the issues in the hereditary cancer space, but also broadly, I think in the screening space, is around the ethical, legal, and the socio-behavioral issues around divulging results, on knowledge about results, but also how they're applied and used or misused. And I just wonder if you want to briefly comment on those issues as well.
Briefly?
I know we could spend a whole day symposium on this topic, but I wonder if, given that we have a few minutes.
Yeah. So, well, I think in terms of ethical issues, there are questions around, I'll just pick one. So, for example, a question about testing minors for adult onset cancers. And I'll just make a link between that and the direct-to-consumer testing because, for example, it's parents submit samples of their kids to direct-to-consumer testing sites and can find out information about their future kids' risk for cancer and Alzheimer's disease, which brings up a lot of issues, including that the child never has an opportunity to make that decision. So I think, generally in genetics, we discourage testing minors for adult onset conditions because of the potential for psychological harm, because we want to preserve the child's autonomy. Testing children for hereditary cancer risk is indicated when the medical risk occurs in childhood. So, for example, it's standard of care to offer genetic testing to minor children for a hereditary colon cancer syndrome called FAP, or familial adenomatous polyposis, because screening begins in childhood and can reduce risk of death in childhood. But of course, now with all of these technologies that we have available, there are ethical questions around doing prenatal testing or testing embryos, or I'm sure at some point we're going to talk about gene editing in embryos. So if you could take out a gene predisposing to hereditary cancer and insert a correctly functioning gene in an embryo, what are the ethical implications of that? And so that's not a brief conversation. But just, it's a brave new world. All of these technologies exist, and there are disparities in who has access to many of these technologies because they are expensive, and lots of ethical issues around balancing parental autonomy to make decisions in the best interest of their child, future autonomy of the child, weighing harm versus benefit. And then in terms of legal issues, one that comes to mind is a duty to warn. So I think that we do feel that hereditary cancer risk is a serious, often foreseeable and preventable risk. And so what do we do in this scenario where we have a patient who knows about a hereditary cancer risk but does not want to disclose that information to any family members? As a healthcare provider, do I have any ethical or legal ability to override my patient's confidentiality and disclose to his or her family members? I could just leave the question out there. In practice, most of the time, I don't have access to those relatives, so it would be hard for me to do that. But I think that and there are HIPAA issues and all kinds of other things. But I think that one could make an argument that in some circumstances it may be legally permissible and perhaps ethically justifiable to override confidentiality if harm can be prevented. So, for example, if you can imagine my patient's sister is about to undergo prophylactic surgery because she is worried about a cancer risk in her family, but if I have knowledge that she may actually be at population risk based on testing negative for a familial mutation, and I can prevent her from having unnecessary surgery, I might be in a position where I could justify disclosing a test result. So I think that the point is that, these issues are complex and complicated, and that we need to be thoughtful about it and weigh everybody's interests and get consultations and slow the process down. And as I tell medical students when we do ethical cases, that many of the issues that we come across are not necessarily ethical problems or warrant ethical consults. In many cases, it's communication issues. So if we take the time to talk with individuals and talk with families, I'd say most of the time we can sort through these issues in a thoughtful way.
Oh, thank you. That was a very important comment. In fact, just wanted to put in a plug for a research program that we have within the Division of Cancer Prevention on something that you referred to around informing relatives when there is a demonstrable benefit to be had from genetic testing. We have a program announcement for funding called Traceback Testing,
Yes.
where we actually use, we have invitations for researchers and, program people to actually come in proposing novel ideas to go back into pathology repositories and biorepositories to actually link to relatives who might be potentially benefit from testing, from the index patient who might have had, a certain cancer that was linked to a genetic mutation that's familiarly associated. And so I think those are very important points that you brought up. I just wonder, in sort of closing out, sorry.
Yeah, so I was going to say that I think that's a great point, because the public health impact of preventing hereditary cancers comes from that process that you mentioned called cascade testing. So we identify an individual who has a familial or hereditary risk for cancer, has tested positive for susceptibility mutation, and then think about your own family, how many first and second degree relatives you have, brothers, sisters, children, aunts, uncles, cousins. All these people then become at risk if you find out that you're at risk for a hereditary condition. And that's how we make the impact in hereditary cancer and other preventable hereditary cancer diseases, is by identifying the mutation and then expanding it or doing this cascade testing throughout the family.
Thank you. I think I just want to highlight one topic in closing. I don't know how many minutes I have, but if I can take about 3 minutes and maybe move rapidly between the three panelists. One of the pervasive issues, we talked a lot about new technologies, talked about some of these fabulous approaches to prevent cancer. A lot of these are tests, are technologies which have to have a solid insurance pool coverage. They are costly. They cost a lot to the system. They cost to the individual patient. And I just wonder, a theme that has come up, obviously, in the workshop earlier is disparities. And, not everybody is, a significant proportion of the country lacks access to a lot of these technologies, either through lack of insurance, but even if there is insurance, there are other barriers, whether they're geographic, whether they're socio-behavioral. I wonder, moving rapidly between the panelists, if you can identify one health disparity issue within your area of expertise, within your cancer area of focus, that you could highlight as being action-oriented or actionable or intervention-oriented, that needs a little more focus, that, organizations like Less Cancer and, the congressional members and staff here could sort of put that on the radar for public consumption and having more discussion. I just wonder, maybe whoever wants to start, maybe Dr. Yoshida or...
I'll start. I guess for me, a lot about it is with regard to insurance. So insurance is a big barrier for colorectal cancer screening. Remember, a number of our earlier speakers today talked about completing the screening totally. So if you have a positive FIT test, you have blood in your stool, you have to go ahead and have a colonoscopy. And having that colonoscopy, the barrier there is the cost to the colonoscopy. But another big barrier that many people aren't aware of is that through the Affordable Care Act, you could pay for colorectal cancer screening. That colorectal cancer screening, if you had a FIT test, which is $71, or if you have a colonoscopy, it will be paid for. But if you have that FIT test and it becomes positive, that's your colorectal cancer screening. And for many insurance companies, they will go ahead and then your colonoscopy becomes diagnostic. So one of the big barriers is the fact that people can have a FIT test and find out that they have blood in their stools, but they can't afford to have the colonoscopy later on. And it's because the insurance company doesn't recognize that it's a continuum of screening, that it still is screening. But in fact, now they have found a loophole and have made that to be. So there are a number of different bills that are coming through Congress. One is reducing barriers to colorectal cancer screening. And I think that's going to be key in improving that.
Sure. Thank you. Mm-hmm. I appreciate that comment. Maybe Tom?
Yes, I guess stigma around HIV leads to many disparities across the entire life cycle of someone with HIV, including cancer prevention and management. And so I think that addressing stigma is a common issue that needs to be addressed again and again. And then trying to better understand the science around what are important immune differences in the immune system and what are perhaps not so important differences in the immune system as they relate to cancer, so that they can be manipulated to potentially lead to better preventative measures for people with HIV.
Sure. Thank you. Professor Peshkin?
I would say a couple of things touching on the other point, that it's not very beneficial to, we have lots of low-cost genetic testing options now, and the labs have been very good about that. But if we identify somebody who has an inherited susceptibility to cancer, who then does not have access to high-risk screening or risk reduction, that's a problem that needs to be solved. The other issue is that we have many people in the Washington, D.C. area, for example, and other places in the country who don't speak English. And so increasing awareness of how to get non-English speaking people into the healthcare system and having access to genetic counseling and testing is something that we're working on. And one of my colleagues has a program where we're training navigators, bilingual navigators, to help identify, in this particular study, Latinas, and how to facilitate their trajectory through the system so that they can have access to genetic counseling and testing in Spanish, and follow up as well, so that they can get the care that they need.
Well, thank you. I think on that note, it's been tremendously useful to hear all your insights. I appreciate your detailed discussion. I know we didn't have a lot of questions for the audience. I don't know how much time we have, but since we started late,
we're going to start lunch here. But
yep.
I first off, I wanted to say we're getting questions in online. You guys have opened a whole can of worms for lots of people that are like me, that are not medical students or physicians or healthcare provider. And the great thing about streaming this globally is that when people hear from the experts, I'm sorry for that, when people hear from the experts, they feel like they have some control over their health. And when we hear these nightmare stories about insurance companies and all these complicated things that, people who are the best and brightest with the most resources can't figure out, I'm so glad that we have, beyond the CMEs, beyond the credits that we provide here, that there are people who are writing in now asking all kinds of questions. This is part of such a big, important question. Because of this workshop, I went through a lot of genetic testing, and I found out I don't have cancer in my genes, but I sure have it all over my family, right? And so, as we learn about these things, just as a layperson, it's a fascinating journey. So I can talk to my kids about, things like polyps or things like, pancreatic cysts. All these things I've discovered through this own workshop. So what I wanted to do is just, because we're going to be starting lunch soon, and we've got a lot of speakers moving through here. Does anybody have a pressing question right now? Right here.
Screening colonoscopies usually are free, but it used to be screening colonoscopies are free, usually free with insurance, but it used to be if you disclosed a family history of colon cancer, that then they called it a diagnostic colonoscopy. Is that no longer true?
That's correct.
Thank you.
It's screening.
But initially, that.
You guys good? Everybody good here? So what we want to do here is we didn't understand we were going to have the flurry of congressmen join us today, but that's always good. because we know that there's a lot that can be done not only through education but through policy on cancer prevention. So we're glad that they're plugged in. We're so honored to have all of you here. Super grateful and glad you could be part of this conversation. When everybody's up getting lunch, it's going to be a little bit of a quick move through. If you have questions that you would like to later address, you want to email me or be in touch with us, be in touch and we will follow up.